And always when I do this, I don't go into a lot of clinical detail about preeclampsia, but had a very nice introduction and an overview of how bad this disorder is. And from what I'm going to tell you guys now over the next 25-30 minutes is how we can avoid all this trouble with magnesium sulfate, alvedolol, convulsions, stuff to stop you biting your tongue when you're having these seizures. So hopefully, what I tell you now, we can try to avoid most of that. So preeclampsia, it drives us absolutely crazy. We're thinking so much, we just can't get on top of it. We know it's a multi-system disorder, and we can see, here that there's lots of, we can see what's going on. There's lots of pathology here, and how all this, oh my God. Is it on my USB stick or is it your computer? So there's lots of pathology going on, but exactly how it starts, exactly what causes it still eludes us, and we still haven't got on top of it. But what we do know is it's a spectrum disorder, and you'll hear many people grading preeclampsia, and I heard Alex speak yesterday talking about very early preterm and term preeclampsia. And you'll see that a lot in all the books. And I think when you put all of these together, it really is a spectrum disorder. And the earlier you get this preeclampsia, the worse the outcome is for both the mother and the baby. And you can see here, the earlier you deliver because of preeclampsia, the worse these babies do, and the worse, the higher the level of perinatal death, the higher the level of fetal growth restriction, even maternal death, and also placenta pathology as well. So you have these classifications, but I think it's very important to remember that it's a spectrum disorder. The earlier you get it, the worse it is. That wasn't me. Okay. So, okay. So what I'm going to talk to you about is how the different methods of prediction for preeclampsia work, and which is best and why. So essentially, there's three ways to approach this. There's a risk scoring method. There's many logistic regression models, and there's our competing risk model, which was developed for a couple of years ago for the screening for preeclampsia. So the one that I think everybody's used to, and I'm not sure if you guys are aware of these here, but in the UK they use the NICE guidelines, which is the National Institute for Clinical Excellence. And what this really does is, this was published in 2010, and you have a series of high risk factors and a series of moderate risk factors. And if any of the patients come to you in the clinic in the UK, we will ask them these questions. And if they have risk factors like previous preeclampsia, chronic renal failure, chronic hypertension, diabetes, lupus, antiphospholipid syndrome, immediately they need to go on aspirin. 75 milligrams is the dose recommended by the National Institute of Clinical Excellence. However, if it's their first pregnancy, if they're over 40, if they have a body mass index of over 35, if there's an inter-pregnancy interval of more than 10 years, or a family history preeclampsia, then they have two of these risk factors, two of these moderate risk factors, they were recommended to go on aspirin, 75 milligrams. And then the Americans have changed their guidelines, and they've just recently published a similar set for starting on aspirin. And basically what they're saying is if you have any of these high risk factors, you should go on aspirin. And if you have one or more, you should consider going on low dose aspirin. Now, what these tests are is they're easy to do. They're easy to do in the clinic. It's a checklist, and you say, okay, I'm going to start you on aspirin if you fulfill these criteria. But the problem with this approach is, this was brought in 2010. It was never tested before of how well it was going to work. It just seemed like a good idea. And actually, when you look at the data, it only really has a detection rate of about 40% for preeclampsia. And it doesn't give an overall personalized risk for the mother. It's a blanket term. And each of these risk factors is almost considered as a separate test. So while it works to a certain extent and seems like a good idea, the detection rate is not great. Logistic regression model, this is a little bit more complicated, but it allows you to look at the maternal factors and all the hidden factors from the history that we've seen from the NICE and the American College, as well as these biomarkers. And what are these biomarkers? Biomarkers are uterine artery pulsatility index, mean arterial pressure, and there are some biochemical markers like CAP-A, PLGF, and SFLT1. And what these studies here can do, and if you have a read of them, they're able to generate risks for early preeclampsia, preterm preeclampsia, late preeclampsia. And the advantages of this is it gives you a personalized risk, but you need to design the models for a specific gestational age cutoff for preeclampsia. And if you want to add in additional biomarkers, it becomes a little bit more complicated. And also, it doesn't take into consideration the deviation from the norm of these biomarkers that could potentially increase the risk and associated with severe preeclampsia. So now we come on to the competing risk model. And I want to take some time to explain to you how this works. So, let's look at the bottom here. This is a curve, a Gaussian curve, a normal distribution curve of pregnancy and the gestation. The competing risks model takes all these maternal factors, and each factor is, and their interrelationship between each factor is taken into consideration into the risk for preeclampsia. So if we consider, so this was an idea by a man called David Wright, who was a very important statistician in the UK, and he said, imagine, listen to this carefully, imagine that pregnancy was to last indefinitely. He suggests that all women at some point during the pregnancy will develop preeclampsia. Okay? And the average gestation that these women would get preeclampsia would be 55 weeks. Now luckily, I've never seen anybody pregnant still at 55 weeks. If you draw a line here at 42 weeks, where most people deliver, the area under this curve would be about 2 to 3%. Now, as your professor said, the numbers vary, and the study and the literature says anywhere between 2 to 8% the incidence of preeclampsia. But in the UK, it's about 2 to 3%. And this represents the area under the curve. So now, what we do is, we have a logistic regression, and we take each of these into consideration. And what this can do is, this looks at the effect on the time to delivery with preeclampsia. So if you have somebody with chronic hypertension, you can see that's a very important risk factor. And what this does is, it moves this curve to the left. And then at 42 weeks, if you draw the line, you have a much higher area under the curve here. And you can add this in with diabetes, you can add this in with whatever other risk factor you have, and at the end you get an individualized curve, personalized curve for a woman, and you can draw the line at any gestation you want to determine their risk for preeclampsia. So then what we do is, it's like screening for Down syndrome. You determine the prior risk from the maternal factors, you measure the biomarkers, mean arterial pressure, uterine artery Doppler, biochemical markers such as PAP-A, PLGF. You express them as multiples of the median, and then you modify this prior risk to get a posterior risk. So you can see an example here. So you have, in a low-risk population, for preterm preeclampsia, you have a very low risk, and then whatever, if they have diabetes, if they have chronic hypertension, previous preeclampsia, family history of preeclampsia, etc., the curve shifts, and you get these risk factors here, and you can cut it off at any point you want. So what this does is, you can see you get a personalized risk, preeclampsia, any desired gestation, and it can be expanded to include additional biomarkers measured at any gestational age. And what this does also is it takes into account the increasing effect of the biomarkers with severity of preeclampsia, and I'll explain what I mean by that. These are the biomarkers that we typically use, and this is from a study of 100,000 patients. I know that's nothing for you guys, it's a month's work, but it took a long time for us to do it. And these are biomarkers measured in the first trimester between 11 and 13 weeks. We have the uterine artery Dopplers, we have mean arterial pressure, we have PLGF. And what you can see is for ladies who develop preeclampsia, and here are the gestational age, the earlier that they develop preeclampsia, the further their values are from 1 at 11 to 13 weeks. You can see the curve there. Same for blood pressure. It might not be elevated so high that they need to be treated in the first trimester, and that's a problem for us as well, because often women are saying to us, well, I don't have a problem with blood pressure, my blood pressure is normal now. But when you look at the mom of the blood pressure, at 11 to 13 weeks, while it's doesn't necessarily need treating, it's higher than the average. And that actually is quite a good marker even later on in the pregnancy as well. But the earlier that they get preeclampsia, the worse their blood pressure is in the first trimester. And of course, it's the inverse for placental growth factor. Placental growth factor is extremely low at 11 to 13 weeks in ladies who develop preeclampsia. And the lower it is, the earlier that they will need delivery for preeclampsia. So, this is all very nice, Neil. Why are you telling me this? What I'm telling you this, the reason why I'm telling you this is when you use this competing risks model, for preeclampsia less than 34 weeks, we have a detection rate of 90%. And actually, in this study that we did, in this study here that we did with 35,000 patients, and these are the numbers that we got. We got a 75% detection rate for preterm preeclampsia, and for term preeclampsia, it's not great. And what we did after this was, this data was generated and tested on the same cohort. So there's always questions and comments about bias. So what we did after that was we did a prospective validation on 10,000 pregnancies using the exact same prediction algorithm, and we got almost identical figures here for the detection rate. And what I don't have here is I don't have preeclampsia less than 32 weeks, and we had a 100% detection rate for preeclampsia less than 32 weeks. So if you remember back to my first slide, the earlier the preeclampsia is, what your professor said as well, the sicker the women are, the sicker the babies are, and we're actually able to detect a huge amount of these and a potential to avoid catastrophes later on in the pregnancy. And I just want to put this into context. because me giving you these figures, 90%, 75%, blah, 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 that's all well and good. But I want to compare it to what is actually available out there already. So we published a paper last year looking at the NICE guidelines. And remember when I said about the NICE guidelines, these were introduced, seemed like a good idea, but it was never tested and it was never known how well this algorithm would, or this screening method would perform. But for the preeclampsia less than 37 weeks, remember R1, the competing risks model, 75% detection rate less than 37 weeks. If you use these NICE guidelines here, it's about half you will detect. So you're going to miss a lot of women just asking them these questions. So it's very clear that we need something a little bit more. And also the Americans, although they have changed recently, this was an older slide before they produced it, before they changed their data, but the Americans back in 2013 were saying that people should only get aspirin if they had preeclampsia in two or more previous pregnancies, or they had preeclampsia one time less than 24 weeks. And if you do that, you're only going to get 5% of pregnancies with preeclampsia less than 37 weeks, although there's a low false positive. Okay? That's just a little bit to put it into context. So, when I was explaining the competing risk model, this study by Min Tan, who worked with me in London, we combined three different studies to get a figure of 61,000 pregnancies with a preeclampsia rate of 2.9%, which is perfectly in line with the rest of the literature. And how does this really work? So what I mean, we've got detection rate for a 10% false positive screen, or a screen positive rate. So what you can see is, even using the maternal factors, so just the history, and changing the approach of the history to that of the NICE, you have a higher detection rate. But then you add in the blood pressure, and this gets a little bit better. You add in the uterine artery Dopplers with the blood pressure and the history, and it gets even better. You take out that and swap it for the PLGF, it's pretty much the same, non-significant change. However, if you use the 3 with the maternal factors, less than 32 weeks, in this study of 61,000 pregnancies, there's a detection rate of 90% for less than 32 weeks. So the sickest people from preeclampsia, you can almost get 9 out of 10. And 75% for overall preterm preeclampsia is the best figure that we have at the moment. It's the highest detection rate for this at the moment. I'm going to skip that. And I'm going to skip this. So, how does this work? This is not complicated to do at all, but it takes a little bit of practice. And once you have a bit of practice in it, it takes about 3 minutes, and I'm not even joking. You do a transabdominal ultrasound. You take a sagittal section of the uterus and the cervix, which you can see here. This is a video that I'm going to do. You put on the color Doppler, and you literally tilt the probe like this. You don't have to even move it. It's literally tilting the probe. And you can see the 2 arteries at the level of the internal valves. Now, it is extremely important, if you're going to do this method of screening, to follow this criteria. Because even now I see people who don't follow this criteria, like, Neil, it doesn't really work, the screening, blah, blah, blah. When I look at the data and I look at this, they actually aren't following the protocol. So the sampling gate on the Doppler should be 2 millimeters to cover the whole vessel. The angle, like in all Dopplers, shouldn't be more than 30 degrees. To ensure that we have the right vessel, the speed, the peak velocity should be more than 60. And again, I don't know how many times I've seen pictures of people who, pictures of ultrasound of Doppler waves that are 30, that are 45, and they're like, well, I don't know what's going on, I don't know why my Dopplers aren't good. It's because you're not following the protocol. You measure 1 on each side, and you divide it by 2, and you get the average P value. That's that done, okay? Blood pressure. I was extremely happy to hear your professor talk about cuff size. We don't talk about contraception to our patients just in case, but it's very, very important to use an automated device. So we were using this for all our studies. It's a MicroLife home monitor, which costs about $60 or so. So we were taking 2 of those. The woman would come into the clinic. By the time we take the history, she's sitting down. After about 5 minutes, we have the arm supported at the level of the heart with 2 stools from IKEA. And then we don't measure the arm, but when you do 61,000 of these, you start to know, okay, this is a small, this is a medium, this is a large. But if you're never sure, this is a guide. And it is extremely important to use the right cuff size. Because if you use a cuff that's too large for the woman, you're going to underestimate it. I don't think I've even ever used this, but maybe this is something that you guys would use here. Because you would have more patients that would require this. And this, if you use this on a lady with a large BMI, or even this one, you're going to overestimate the blood pressures. And I'll show you what happens to this. You think, it doesn't really matter if my systolic is 5 millimeters of mercury more than it should be or lower. It doesn't really matter. Yes, it does. We do both arms, 2 measurements in each arm, and we take an average and we convert that to a mom. So, I'm going to give you all the risk factors again, which you have seen many, many times. So the collection of data is very important. So the accurate recording of maternal factors, so we need to be absolutely sure that we're recording everything and we're not missing anything here. I have some medical students that forget to ask if it's a spontaneous pregnancy or a pregnancy of IVF. People forget to ask if it's a family history. And what do we mean by family history? We mean, is it their mother or is it their sister that had a history of preeclampsia? There's a bit of debate over this as to we can be really sure if the patient's mum had preeclampsia when she delivered 25 years ago. But that's the best we can go on for now. So, training and audit for the blood pressure, training and audit for the uterine arteries, and also validate the reagents and audit for the central growth factor. As I've said already, you need to convert these to moms, because a lady of Afro-Caribbean origin is not going to have the same raw value of central growth factor or blood pressure or uterine artery doctors than a white lady from the Middle. And this changes. So we need to adjust the momming equations as appropriate. The outcome measures need to use the appropriate definition. We've seen the professor and he has shown that there are many different societies. We use the ISSHD definition, so that's 140 over 90 with 2 pluses of protein more than 6 hours apart, or a urine PCR more than 30, or 24 hours at 0.3 grams of protein. Ensure that the diagnosis is correct. So how did we get this data? I can't tell you guys how many nights and weekends I spent going through medical notes of patients to see was it really preeclampsia or not. Because it's very difficult on the labour ward, because you're doing it's either us or it's the interns or the medical students or the midwives. And on the labour ward, and you guys are going to be even busier than we have been, and you record preeclampsia. But was it chronic hypertension? Was it really preeclampsia? So we spent so much time digging out all these notes to see if the diagnosis was correct. And then, now that the Asprey study, which I'm going to speak about in a second, is done, it's very important to calculate and adjust for the use of aspirin, because otherwise you're going to say, well, the screening doesn't work. And the performance of screening, these depend on the prior risk and different cutoffs. We were using a cutoff of 1 in 100 for preeclampsia less than 37 weeks. So, how can we do the training and audit? So after a certain amount of time, maybe a month or 2 months, maybe a week here, you can look at the blood pressure. Green means good, yellow means a warning, red means what the hell are you doing? And what I used to do was I used to go. This is data from our studies, and these are the hospitals which we didn't put the names of the hospitals on. And it was very obvious that in certain hospitals they weren't measuring the blood pressure right. And you'd say to me, Neil, how could you not measure the blood pressure, right? And it's actually very easy not to measure it correctly. It's very easy that the woman has just walked into the room and you're half an hour running late on your scans, and you say, okay, Mrs., have a seat there, I'll measure your blood pressure straight away. If you measure the wrong curve, you get rid of this. So you measure it too quickly. You don't have it at the right level of you don't have it at the level of the heart. You have the wrong pulse, and you think that this wouldn't really make a difference. And I remember going to a few of these centres, going, look, this is you here. What's going on? And they were like, okay. And actually, we can be even more strict, because in this hospital here, I can see each person and what their distribution is as well. So it's a real military option. So you don't even necessarily have to train everybody. You just train the people who are not doing it correctly. And then they will, if you go to, I remember going to these people and they were saying, okay, I'm in a bit of a rush, I haven't been doing it properly, okay. So you do some retraining. And then, because this will affect the screening algorithm. And green is perfect, as I said, and it's just, you can look at the data for the orange or the yellow and say, okay, take care, you're not quite perfect, but you're not too bad. And this is the same for the uterine artery Dopplers, and then the guys in the lab can do the same here. And one of this center here, I remember very well. The PLGFs were all very, very low. We had a huge screen positive rate, and couldn't get our head around it. Had a look at the data, and the PLGF was extremely low. So what then we needed to discuss with the lab, we needed to investigate why was it low, was it a new batch, was it a new machine, blah, 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 and in the end, we ended up having to adjust for the months. So this is an extremely useful tool, and if you're going to implement a screening system like this is absolutely imperative. Prevention. Why are we investing all this effort into screening for preeclampsia? Because we can actually prevent it. This is an old study from '85, which was published in The Lancet. It's a study that comes from France. And it was a randomized study with 102 patients who were at high risk for preeclampsia and growth restrictions. And they used antiplatelet therapy, including aspirin 150 milligrams, from 12 weeks, that was group A, versus no treatment in group B. And in these 102 patients, the patients who were treated, there was no cases of preeclampsia, no cases of fetal death or severe growth restriction. When compared to the other group with no treatment, and these differences were statistically significant. So, and what they noticed was the treatment didn't provide any problems. I know the numbers were small. And what they concluded was that antiplatelet therapy given in pregnancy to high-risk patients may protect against preeclampsia, growth restriction, and stillbirth. This is in 1985. I think there was probably more than 50 studies done since then, with various different definitions, various different treatment options here, but a very important paper from the Lancet in 2007 by Askey. They looked at antiplatelet agents for the prevention of preeclampsia and did an analysis. So they had 32,000 women with 31 trials that included 23 trials for aspirin. And what they found was that antiplatelet agents did decrease the relative risk for preeclampsia by 10%. It's not a huge figure, but it did decrease it. So it needed to look into this into a little bit more detail. Because there is some evidence, but we don't know exactly what we can extract from this study. Because they use 14 different definitions of preeclampsia in these studies, the aspirin dose varied a lot as well in these trials, and you can see that most of them, so almost, well, except for 2 studies, the aspirin dose was less than 100. And in 20 of the studies, the gestation at randomization was after 16 weeks. And you'll see why I'm pulling these out now. Because we're looking at this figure here, So what I'm trying to extract from this is that more research is required. And what happened after that? A group in Quebec in Canada, Emmanuel Rougeau and Stephanie Roberge, published a series of meta-analyses. And when they looked at it, for aspirin, given less than 16 weeks, there was a huge reduction in preeclampsia. But over 16 weeks, there was still a reduction. And the numbers were much greater in the group that were given aspirin after 16 weeks. But there's a huge difference, statistically different risk, in reduction in risk. And like the guys in France said back in '85, fetal growth restriction and perinatal death, again, if aspirin is given less than 16 weeks, there is a huge reduction. So you're looking at a 55% reduction here. So this is why it is extremely important now to move screening towards the first trimester so we can identify a high-risk group that can benefit from treatment. And Stephanie Roberge also found that aspirin is also much better for preterm rather than term preeclampsia, with almost no effect on the term preeclampsia. So, what did we do? At King's, when I was working there, we did a double-blinded randomized control trial. We used the competing risks model that I've just talked about to screen all women. And we had about 13 different centres. We had centres in the UK, we had centres in Brussels, we had Milan, Spain, and a centre in Athens. We used the exact same screening model, and we had almost 27,000 women. You have a screen positive rate of about 10%, and we estimated that about 50 to 60% would say yes to participate in the study. So what we ended up doing was we had a double-blinded, two arms. We had one assigned to aspirin and one assigned to the placebo. And we gave them 150 milligrams of aspirin every day from about 12 weeks up to 36 weeks. And what did we find? The primary outcome was really aspirin, less than 37 weeks. We had a 62% reduction in the rate of preterm preeclampsia. The aim was to have a 50% reduction. And if you look again at less than 34 weeks, we had an 82% reduction in preeclampsia. Phenomenal decrease in the groups. And an 89% reduction in the really sickest patients, both baby and mum. And just as it was published in the meta-analysis, it didn't really have any effect on term preeclampsia. Another thing that we spent a lot of our time doing was asking women to bring their tablets with them when they come to the clinic. So every day I was counting tablets going, how many have you taken, how many have you missed? They're like, oh, I'm sorry Neil, I missed it last night, don't worry about it. So what it was published after that, this is David Wright. This is David Wright who invented the competing risk model. Their article showed that although we had a 62% decrease in preterm preeclampsia, in women who took more than 90% of their tablets, we had an even bigger decrease in preterm preeclampsia. So that really helps a lot, because when we're armed with the information from this study, we can say, well, we know if you take aspirin, it will decrease your risk of preeclampsia. But if you take it every day, you have an even better chance of preventing the risk of preeclampsia. When we looked at the different maternal factors, and these are some of the risk factors, or some of the groups, when we looked at the response rate, Professor mentioned about smoking. Actually, the way smoking works is it does decrease the risk of preeclampsia. But actually, those who do smoke, if they get preeclampsia, it will be much worse, and they have a higher rate of developing eclampsia. And I think the reason why we think this, they have a lower rate of preeclampsia is because in the cigarettes you've got nicotine, which is a vasoconstrictor, and it doesn't have a very long half-life. So that goes straight away. But what lasts much longer after that is carbon monoxide, which is a potent vasodilator. So we think that is why. I'm not having very much luck here, am I? But what the meaning for this slide really is, people used to ask me, was there any group in particular who responded better or who didn't respond at all? And these chronic hypertensives, they didn't seem to respond very well. Now the numbers are very small, you can see them here, but we don't know why. Is it the same pathophysiology? Does it work the way aspirin works? Does it work in a different way that these people get preeclampsia? And the honest answer is that we don't know. So so where are we? We have a screening method that works very well. We have that's put into place with a lot of audit and research to ensure that it works. And we have now an effective treatment in aspirin. A lot of people, and especially in the US, it's very difficult to convince people this because it sounds very complicated, it's complicated mathematics, it's much better to ask questions, maybe we should just give aspirin to everybody. But actually, it has been shown to be cost effective from the aspirin study. This is our study here, aspirin group, placebo group. There was no difference in the rates of admission to the neonatal unit between the two groups. No difference. However, the total length of stay, 11.1 days and 31 days in the placebo group, was significantly significant between the groups. So the people who had the people in the placebo group, if their baby went to the neonatal unit, the babies tended to stay there much longer. And if you look at the whole population of our study, on average, per patient, it's 0.6 of a day in the aspirin group and placebo, 2.6 days, 2.06 days, sorry. So what does this really translate into? And these numbers are much, much bigger for you guys, and I'm not sure how expensive it is per admission in the neonatal unit here. But if you've got 10,000 patients with a 10% screen positive rate, that means you've got about 1,000. That means you've 1,000 patients you're going to tell has an increased risk of preeclampsia. So you multiply this by these figures here, and if you compare them, 2,000 versus 666 days, at about $4,000 a day, that's a $5.6 million difference in cost to admission to the neonatal. And that works out at about $560 per patient screen. And actually, to screen a patient costs much, much, much less than that. So I'll finish up. I want to just reiterate that the competing risk model, remember, has a significantly better detection rate than using the NICE guidelines or the American College guidelines for preterm preeclampsia. The detection rates, you can see the different permutations. And I haven't talked much about PAP-A today because it doesn't add much when you've got the central growth factor involved at all. And you can see that maternal factors plus the biophysical markers work well, 70%. If you can't do uterine artery Dopplers for whatever reason, and you have a lab, your blood pressure, and it's a little bit better. However, if you can do the three of these, you have about a 75% detection rate for preeclampsia overall, less than 37 weeks. But this is close to 90% for the sickest babies, less than 32 weeks. And it doesn't really work that well for all preeclampsia. So if you give aspirin of more than 100 milligrams, less than 16 weeks, you have a reduction in preeclampsia of 90%, less than 32 weeks. A reduction in preeclampsia less than 34 weeks of 80%, a reduction less than 37 weeks by 65%. I haven't gone into this data here about the eruption, but it doesn't appear to be associated with the central eruption, which is one of the questions that we had when we were doing the study. And we've just seen there in the length of stay, there is a 65% reduction in the length of stay for babies that were admitted in the aspirin arm rather than the placebo arm. I thank you very much for your attention.